Health program here at the U of A in the Faculty of Medicine. And it really gives me great pleasure to introduce our speaker today, Dr. Wayne Clark. Wayne's the Executive Director of the Indigenous Health Program for the Faculty of Medicine and Dentistry here at the U of A. He's originally from Churchill and is an enrolled Inuk of the Nunavut Land Agreement. And from 2013 to 2020, Dr. Clark was the Director of Indigenous Health Services for the Winnipeg Regional Health Authority, overseeing Indigenous language interpretation, discharge planning, and patient advocacy for Indigenous patients within hospitals and other health facilities. He also worked for other government agencies in health, research, and industry. Dr. Clark is a board member and treasurer for the Canadian Society for Circumpolar Health and a fellow of the International Arctic Science Committee Social and Human Working Group. And today, Dr. Clark is going to talk to us about decolonizing Indigenous medical education. So Dr. Clark, the floor is yours. Thanks again for taking time to join us.
Thank you, Dr. Alain. And it's really my pleasure to be here today to talk a little bit about decolonizing medical education and what that looks like. It's something that we've been looking at for some time with the advent of cultural safety in the mid-2000s. That was brought over to Canada by a couple of scholars, particularly Dr. Barry Lavallee, who is a significant advocate for Indigenous patients in Canada and has worked closely on the Joyce Saskatchewan and Brian Sinclair files, and has been very vocal about racism in the healthcare system, and including the institutions such as medical schools. So that is my topic today. I will start off with the land agreement. Okay, here we go. Territorial acknowledgement. So the University of Alberta, its buildings, labs, research stations are primarily located on the traditional territory of Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, and Ojibwe, Saulteaux, and Anishinaabe nations, lands that are known as part of Treaties 6, 7, and 8, and the homeland of the Métis. The University of Alberta respects the sovereignty of lands, histories, languages, knowledge systems, and cultures of First Nations, Métis, and Inuit nations. So the overview of my presentation today includes a discussion about the Indigenous research paradigm. We cannot have education without research, and particularly Indigenous pedagogy and the ways in which curriculum is designed, which has, of course, the science behind that. There's also Indigenous pedagogy, which is very specific to an Indigenous worldview. There's indigenizing pedagogy, and then there's relational pedagogy, and I'll talk about the two of those and how to bring that into a medical context, as well as the distinctions, approaches to curriculum design involving the community, and the distinction-based approaches to policy and how that impacts the ability to change curriculum of any kind, but particularly how we approach the Indigenous medical education component of that. I'll end with a case study to get a sense of what those graduating outcomes might look like in an OSCE exam, and then we'll have time for Q&A. So first of all, I think that when we look at indigenizing or Indigenous medical education, it is really an opportunity to change, and that is that the pedagogy of as an academic concept is really that process of looking at not only the learning that occurs at the university level, but throughout our professional careers. And this is certainly true of an Indigenous pedagogical perspective, in that learning is lifelong. We see this as learning by doing, and that is not only a process, but it's a theoretical position, which has been described by a couple earlier scholars in Indigenous research and Indigenous education. Both of the scholars cited there are Indigenous and have been earlier scholars in this area. So the approach to teaching, learning, and assessing, this comes from my dissertation, is coming from an Indigenous pedagogy, there is an argument for this in Indigenous medical education, and that is when we look at learning by doing, it's really about teaching and learning and assessing. And that's in a constructive alignment theoretical framework that was first brought to the Academy by someone named John Biggs. And Biggs and Tang, his scholarly partner, began to look at this from, how to realign teaching within the Academy by simplifying this and using verbs and ways to align intended learning outcomes with assessments and teaching activities. And of course, with the approach that I'm looking at from an Indigenous perspective involves elders, because elders have always been the ones that have led the way in terms of teaching inside the communities, and how elders are approached and brought into these kinds of discussions is something that we're learning how to do within not just the medical education process, but just how we engage Indigenous communities overall within the Academy. So critical theory is one aspect that started the Indigenous educational process. After World War II, there were Indigenous veterans who came back from fighting in the wars, and they were enfranchised as a result of joining the forces. They had to basically give up their Indigenous status, the First Nation status or the like, and that was then that meant that they couldn't return to the reserve. Same thing was if you went and got a degree, but you no longer had Indigenous or First Nations status. But in the case of the veterans, they weren't treated the same as the non-Indigenous veterans. Like they weren't given war, like those post-war homes, things like that, the same kinds of benefits that other veterans got. And so these men had, thought, well, what were we fighting for, right? And so that became, these were earlier leaders in political movements. And that started to realign or envision what the political process would look like on reserve in particular, and what that process would look like for voting in chiefs instead of having them appointed by the indigent and so forth. So that was sort of the beginning of some of the changes that we see that continue today. There was also the civil rights movement that was taking place in the United States, which then triggered other movements with other critical race theory and other gender equality and so forth. And so the North American Indian movement was quite huge, and that was sort of around the late 60s, early 70s, which was around the time that white paper came out by the federal government at the time, which looked at getting rid of the Indian Act. And then that was responded with the red paper, which was basically the beginning of the Indian Brotherhood, which is now the Assembly of First Nations. So that was that sort of political movement, but it also then established ideas around critical race theory and other approaches to Native studies that were not anthropological in nature. They were based on traditional beliefs, and that really revisiting of traditional values and bringing those into the Academy. And that began, the tradition of Indigenous education, Indigenous pedagogy. So Indigenous education was some of the very first things that were done here. And of course, Native studies is the tradition behind that. And so with the Indigenous scholarship that has ensued since then, we've not only looked at Indigenous pedagogy, but there's an Indigenous research paradigm that is basically a fifth paradigm, if you think of positivist and post-positivist and interpretive and critical and applied research. And a lot of the work that we would do in Indigenous medical education would be a combination of these. Like anything within the Academy, we take what we need. So applied research is really important when we're looking at ways to describe, how to improve, processes, quality improvement, cultural safety within clinical environments. And I'll talk a little bit about that as well and how that gets achieved. Oops. Where were we? Okay, yeah, and then decolonization is, of course, one of the main aspects of how do we approach this, because we have to undo some things. And this is often driven by self-determination of nations, but the individual scholars who support this work. And it's very important that this work is led by community and is facilitated by members of these communities. So the Indigenous research paradigm, this is that fifth paradigm. So that's on top of the other four that I just mentioned. And so the fifth paradigm is looking at specifically Indigenous ways of knowing. And it has that tradition in critical race theory, but it then gets characterized by some of the other aspects of what that, Indigenous epistemology looks like, but also the other components of, an ontology and axiology and methodology, where these are interrelated with one another. So because of the ways in which Indigenous peoples look at the world through that lens, you see the connection to the land, the animals, the air, the water, the environment, each other. And so when we think about, thinking about something like how we would see the world, how the world is seen, all of that kind of comes together in one vision. And so that was first described by a scholar named Sean Wilson. He's from the El Pasquoyat Cree Nation in Manitoba, so close to us here in Treaty 6, and has been really somebody that has been quite celebrated in this space. And also, it's an area of research that cannot be subsumed by Western dominant approaches that could be really counterproductive to the work that we do. And it's not necessarily seen as something that is working against those other paradigms. But when we are trying to establish ourselves within the academy with this, it often does feel like that, because we aren't necessarily going with that flow, where we have our own ways of doing things. And I think that's starting to be recognized a lot more than it was, even 10, 15 years ago. So that should be celebrated today. And then that relational piece is again, that blending of those in that continuous cycle, but it's also a way of looking at pedagogy. I mentioned earlier about indigenizing pedagogy, but there's also relational pedagogy, and they're different. So it's really important to first look at, like, what is the perspective of the colonizer? So this is what we know that's basically been documented in history. So we have that discovery. There's the original, I put James Cook here because I wasn't sure who it was, but I know Jacques Cartier had something to do with coming to Canada. I'm not a historian, but there was two main, before settlers, prospectors, and that was the Northwest Company, the French, and the Hudson Bay Company. So they were the first really to come and colonize, and they were subjected to come here through royalty and the establishment. And so that was the beginning of colonization. We started to see population decline with the introduction of European diseases, and also the movement, basically, of Indigenous people from the east to the west. And so a good example of that is the Ojibwe peoples of Ontario continued to move, and you see a lot of Ojibwe now in Manitoba and also into Western Canada. And that was with the settler movement that started to occur after the the fur trade ended, and then we had the Indian Act and the federal Constitution of Canada and so forth. So and that sort of gets into that acculturation phase, which is the reserve system and the Indian Act, right, which started all of that. And so prior to that, in that fur trade phase, that era, we worked well together with everybody. There wasn't really a government in place yet. Those treaties that were signed in the East, they were all done with the Crown. They weren't done with Canada. And then where I come from, my family's from Nunavut, and in Nunavut there wasn't a land agreement until the 1990s. So we were part of. There was a clause in the Indian Act. It's now been replaced because of our own land agreement. But these things were occurring like all at different times because, of course, Canada wasn't settled all at once. And then we have reinvention, which is basically the enfranchisement of Indigenous peoples. And there was a belief that that we would all just eventually blend into Canadian society, and so that we no longer would exist. And of course, you've heard the story or the term, kill the Indian from the child. That was part of that process with the residential school system. But there's also a different perspective, and this is one that has only been really considered more recently, and what contact and invasion would have felt like from that discovery perspective, and what that initial exploration meant, prospecting and looking for furs for animals, and eventually killing off beavers and buffaloes and those that were not only important to our own livelihoods, but our ecology. Beavers had a very important place in the ecology, which some of you may be aware of from environmental science. And then what that dominance looked like. It was always, a European dominance in terms of how negotiations took place. And we know that now from, perspectives of what the treaties really looked like, and what the perspective was and what they thought these would eventually turn out to be. Genocide was that other aspect of, again, those European diseases, but there was also that land possession and so forth. And so there was a feeling that, hey, this isn't going right. So when the treaty started, Treaty 1 and so forth, when they got here in Alberta, there was already sort of, there was a rebellion that took place in Saskatchewan. And that wasn't just Métis, that was a lot of Western Canadian settlers that said, hey, you know what, we're getting screwed here. Sorry for the language, but there was, when the train was put forward across or built across the North American Divide, was also to ensure that there was that sovereignty along the border, and there for purposes of war, if those needed to come in place, because there was already some of that taking place in the east. And there was initially, when settlers came to Canada, it went up the Yellowhead Highway, which we know today, and came to Edmonton. So there wasn't that train route, and so all of these farmers and settlers were like going, hey, wait a sec, how are we going to get our wheat to market? That was happening at the same time. So there's a tradition in the West that we should all be proud of. That is a part of what that looked like, but we were very much, the Indigenous people were all very much part of that. We supported the Métis in that rebellion. That was actually a civil war, but there is no plaques that state that. It's not in the history books, and that's a whole other chapter of history. But that was when we started to see more resistance and survival happen after the 1920s, because this is when we really started to see those treaties kick in. And there was like, okay, wait, now this is not what we thought we were getting into, and that played out particularly after the Second World War, like I mentioned. And now we have recovery, and the recovery is that cultural revitalization. We have, we have dances like round dances and sun dances, say in the prairies, and in the north we are starting to revitalize some of our traditions as well, going back to what is called Inuit Kalyalektuk, which is traditional knowledge and the way in which that played a role in our survival in Inuit culture. So this is where you bring together those Western worldviews and the Indigenous worldview, and then finding that space in between. So I say this is a great approach for looking at how to bring in Indigenous pedagogy with Western approaches, say, to Western medical education, in a manner that you can do these things together. And just thinking about this vision for a second, and as I carry out the rest of my presentation, you'll see why this is important. This has been coined as called an ethical space by Willie Ermine. from, I believe, I think he's in Treaty, around the Saskatchewan area. I don't know if it's Treaty 6 exactly, and someone named Albert Marshall, Mi'kmaq elder as well. So indigenized pedagogy, that's when we take a Euro-Western concept and then we make it more Indigenous friendly. So it's a process for critiquing and resisting imperialism, but upholding our values. And so it's a framework for decolonizing curriculum, and it can be applied to medical education as well. It can also be, so we take, say, if you take the classic example of a case study that we use in medical education can actually be retold through the vision, or through, sorry, the eyes of an Indigenous person. And we use stories. So if we take storytelling and use that as a way to teach, and looking at sort of, this perspective and then how that would be addressed, was very similar to how we teach with the case study. And so it could also be done with that learning by doing that I talked a little bit about. So we can see how, Indigenous people want that transformation to look like, not just in Indigenous medical education, but the healthcare that they receive, because that's where they see it, not necessarily at this end, right, which is really more, upstream. And then the assessment criteria is also going to be based on the realization that these learning outcomes have taken place, or at least the beginning of that, because when we would probably have a chance to really see that through until the end of, say, third year, with some exams, and looking at how we can ensure that, okay, if we have specific criteria at the beginning of medical school, and then students know that they need to eventually speak to this in an oral exam, that they're going to pay more attention across years 1 and 2, and we need to do a better job of making sure that that is actually understood, and that is an intention of what we are wanting to do in the time that we have with the students. So the relational pedagogy, this is becoming more holistic, more specific to that Indigenous perspective. So this can be very specific to a story, because that's going to be completely relational from an Indigenous perspective. But it's also around that thing about bringing all those elements together. So it's not necessarily indigenizing pedagogy that already exists. This would be replacing it with a different perspective. So I think this can be brought in when we look at some of the things that we have been doing so far, like looking at cultural safety, or looking at historical perspectives and what those mean today, what they've done and what they mean in the context of in a postmodern perspective. That is we've done that to date, but we haven't applied it to clinical practice. And so that's where the indigenizing piece comes in, because I don't think that relational pedagogy would work there yet. It might someday, and I'm hearing about places where you've got traditional healers and traditional knowledge and traditional medicines in a clinic. And I'd be really interested in seeing a study of that. That's now happening in Canada. But there's still not a whole lot known by those in medicine about how that actually works and how we can make those improvements in the system. So when we think about distinctions-based curriculum design, then we need to bring in the voices of the people. And so right now we have modules, and this is very similar across Canada. But I would say, where can we look? We do a wholesale review of everything, and where can we place more Indigenous content within the curriculum, so it's not just these one-offs that are attached to, that it's integrated within their curriculum, or at least touched on a little bit with some signposting, and vice versa, right? Depending on where in the modules that might connect. So for example, in infectious diseases, we can look at TB, which has a prevalence in some communities. And so looking at, well, it's not just the disease aspect of it. What about the living conditions? What about the drinking water? What about the lack of health system infrastructure that exists in these locations, the lack of population public health, and then start to look at it from that lens. And then also finding a way to involve community in the development of curriculum and ensuring that that copyright exists. And that's really important, not only for copyright, but it's also important for ensuring that inclusion. Currently, we have Indigenous, cross-cutting Indigenous, medical education, but we really should be approaching this from who our neighbors are. If the land or the territorial acknowledgement does that, well, then let's work with those community members here. And the same could be said out east, and so forth. We do have to be careful, though, that we are including Inuit and Métis, because those groups are across Canada, just as people move around and stuff, like from other parts of Canada. But when we are here, and the way it's been mentioned to me since I've been in Alberta as a guest, that I do things the way it's done here. And so even as someone who is Inuk, my approach here is going to be respectful of what happens here. And then, so this is that learning by doing, the John Biggs and Catherine Tang model of constructive alignment. So you've got learning objectives, which are essentially your intended learning outcomes, or intended graduating outcomes, if we think about what we want in year 3 and 4. And then what those learning activities are, or those teaching activities, and then how we do that assessment. So that learning assessment is going to also be based on, what those intended learning outcomes are. It's just sort of, looking at, those verbs and looking at, has that been achieved? And when I say the need for, beginning the journey is recognizing that, yes, that light bulb is there, and they're going to continue to do this when they go on and practice. And that there's a willingness to do that. And I'm seeing that there's students that really want to learn this. They really have recognized that there's a need for it, and they want to learn it. Whereas in the past, it's been kind of like, okay, how do we do that? And we can't treat this group differently, that kind of thing. It didn't fit within the existing teaching model, and it didn't exist in the healthcare model either. So we look at, say, a patient-centered approach now. We can probably look at that a little bit better and look at the efficiencies that go along with that. So now policy. Policy has got to be one of the biggest drivers of getting this done, because we need to ensure that, everything that we are intending to do based on the accreditation standards that exist, and not just that, but other things that we're held to, including, those that are set by the university, the governors, and so forth, is assuring that those policies can be aligned to what we're doing. So I think the accreditation piece has got to be the first place, and that obviously is beyond a university, but I think supporting the organizations that can advocate for those changes, because currently within CACMS, it's in accreditation standards, it's a paragraph basically, but I think we can do a little bit better than that, and looking at standards that would be, I think, more aligned to making some of this happen. And people say, well, it's there, right? But then when we look at, say, the teaching and learning environment, say within a teaching hospital, where you've got potentially a group of people that are from, managed by different institutions, or at least the behavior is. And so therefore, you've got the colleges, you've got the health authority, or you've got the university. And so when something happens there that's unsafe, or not following some of these approaches to making these kinds of improvements, then it's like, well, what are we doing this for, right? And so those staff members, or those other colleagues, they also need to be caught up in this stuff, so that when we are teaching students, that they go into those environments where that's being practiced. Currently, that's not happening, or it's not aligned. And so that needs to happen, and that's what I mean by looking at policy and how we look at that. And just related to that, I think there's a way to ensure that faculty are also kept up to speed. And I think, okay, here we go. So we need to also ensure that, like, we can't have students that know more than the faculty, because what does that tell the students? It's that this isn't important. So there is something that is to be said, where we need to, like, first, ask. I think it's time to survey faculty members and I say this broadly from across Canada, to determine what's the best way to do this. I do recognize how busy everybody is, but if it's not prioritized, it won't happen, right? And so once we know what those standards are too from, from other bodies, then we can start looking at ways in which we ensure that our faculty have what they need in order to teach, or at least to support this process, because recognizing they may not be teaching, they may not be involved in every single block or when we're involved doing our modules, but how that gets parlayed across faculty. Okay, so here's my case study. So say this is a 62-year-old patient. He's let's say he's in internal medicine, and he complains to the attending physician, to you, the student, or you know what I mean. And so the patient explains that he's talked to somebody. He calls her the RN, or him the RN, and he's not quite sure how to say this, but there was something wrong with the drug, with the med rec, and so he mentions that it's a painkiller, right? And so the RN responds. I don't even know when we use the term RN anymore, but anyway, I just wrote this last night, and so he responds, cursively, saying that he's going to look into it, and rolls his eyes. But often the thinking is that that we're drug seeking. That happened. There's so many complaints come up about that, and this is exactly what was happening behind the scene. And so once he explains this to the doctor's thinking, and the nurse says, you don't want me to be, you don't want us to treat you differently, do you? Kind of thing, and doesn't necessarily understand. But I think what he's trying to get across is that he's been through a lot in his life, and there's actually research that has shown that those people that have been through high levels of trauma have a higher tolerance for pain. And so when someone really needs pain meds, they need pain meds. And so how do you respond, right? So I'd like you to just think about that for a second, because often what does happen is a little bit happens, but not enough happens, because of course we have to respond to something like this. Now, these are a few factors, and of course someone could come back with a list of these, but I want to just emphasize a few things. First of all, there's an inherent fear of colonial systems, including the healthcare system. So if there's a drug, like a drug information error, that could be very much about systems not connecting together. So what's being printed out from the drug information system, even if that's provincial, it may not have everything in there yet from a federal system. Like if it was just dispensed at the nursing station before and not included on I think they even said paper still, with the Medivac. And so that could be an issue if it got missed or something. And so that they're relying on what's in the provincial system may not be included there. And often we don't know what these drugs are called. And the federal government uses, generic drugs, like novel drugs. And so they may not have the same names. They don't necessarily, every patient, and you all know this, don't know that entire list and what those names are. They just know what they help them with, but this is also a patient safety issue. And some of these things that happen don't actually get reported. And if we actually did report them all and analyze them, we could kind of look at them and say, was racism involved with this? What if she have treated, well, first of all, she wouldn't have had that issue because the med record would have been actually probably pretty accurate. I mean, there's potential it couldn't have been, but in this case, it was as a result of the federal and provincial system not being equivalent. And then you've got, you want to ensure that the patient gets the right medication, and that the nurse's behavior gets, we have policies for this. So if there's racist behaviors, then we need to follow those rules so that that individual can be dealt with. One way that we can look at this takes time. Dealing with all this takes time. And if we have to put the nurse through training and we have to follow up on this, we're taking away from other things we could be doing, other patients that we could be seeing, and it costs us. And if we look at it from a cost perspective, then, we'll see something actually get done usually. And I think it's important that we apologize to the patient. And it's not just like, oh, I'm sorry. It's recognizing it's okay to have, you know, dimensions, like having conversational dimensions about, you know, systemic racism, to say, you know, this happened because X, Y, and Z, and it's not your fault. And they know that. They already know that they're coming in from a place that's not connected to the system. So it's okay to talk about that. But instead, we often cover that up. And then should this also be reported to quality, right? Because maybe quality needs to look at a better way to manage this, not only from the two systems that are happening, but you know, how this actually gets looked at when we see that there's a potential error, you know. And so that's just one example. I would like us to be able to get to the point where this complicated case could actually be on an exam, on a normal exam. And if right now we wouldn't be able to do that, right? But this is what students, or what, you know, young physicians are going to be facing when they go to the system, because this stuff is all over the place. So I think that's kind of it. I mean, I could go on for hours, but I wanted to really just give an overview of what we need to do to start, you know, thinking about this as a discussion. And I want to work with my colleagues in a manner where they understand what these issues are, and so how we can work together and support a process for making these kinds of improvements. And as an Inuk, someone who's worked a lot with pan-Indigenous approaches to things, I often like to leave my presentations with something that's specific to what a great Inuk leader had said. And so Jose Kusakak was one great leader. And he was the person that coined the saying, Canadians first Canadians. And that's it. That's an Inuk or an Inuit perspective, where we're asked, are you Canadian? And it's like, well, yeah, we see ourselves as Canadian, but we also see ourselves as Inuit. Inuit are also the people of the circumpolar. So we have cousins in Norway and Denmark or Greenland. And so when we go to circumpolar conferences, we see ourselves as Canadian, right? And so we're quite unique in that context from the rest of Indigenous peoples in Canada, because we do have relatives across the globe. And I only just realized this when I went to Copenhagen a few years ago for a conference and just, met people, and I thought, wow, so I like to sort of give a little personal, anecdote to what I'm saying here and why it's important. And I hope that someone there appreciates what I'm saying. And just thank you very much for your attention. Oh, this is a great screen. But I'd like to open up for any questions that anyone has.